All right, good afternoon, everyone. We're going to go ahead and get started. It's 12 o'clock. I want to welcome everyone to Medical Grand Rounds at the University of Colorado. A little bit of a teaser for the upcoming weeks. Just of note, next week is online only. It's a systems improvement conference, so do not come in person, but do show up online at 12 noon next Wednesday. And then the following week, I'm really excited to welcome Dr. Shelby Sullivan and Victoria Catenacci, two excellent clinician researchers talking about weight loss and obesity, intermittent energy restriction, as well as endoscopic therapies, a tale of two novel strategies. As a reminder, CME and MOC credit are available for all talks. And now I'm really pleased because I get to welcome two of our incredible chief medical residents, Dr. Sarah Haeger and Dr. CJ Mowry. A little bit about Sarah first. She was an undergrad here at the University of Colorado, where she graduated magna cum laude with a degree in chemical and biological engineering. She then stayed at Colorado as an MSTP medical student, where she, in addition to her MD degree, received a PhD in pharmacology. She joined our residency program, obviously, and was a member of the physician scientist training track, as well as the medical educators pathway. Sarah is a highly accomplished and awarded both physician and scientist, even very early in her career. Her PhD work included time in Dr. Christy Anseth, as well as Dr. Melissa Mahoney's lab up at CU Boulder. She spent time with Dr. Steve Makowski at the CU Cancer Center before ultimately completing her advanced studies and her PhD work with Dr. Ruben Tudor and Eric Schmidt in the Division of Pulmonary Sciences and Critical Care Medicine. And if you wonder, is she just a scientist? The answer is obviously no. She was also our Alina Kazarian Intern of the Year for outstanding clinical service as an intern within her class of residents. CJ started his career at the University of Washington, where he also graduated cum laude. He was then a medical student at Northwestern University. He joined our residency program, where he's a member of the categorical track and also the medical educators pathway. When he was at the University of Washington, he was named the Mary Gates Research Scholar, as well as a Washington NASA Space Grant Consortium Research Scholar. He then took that experience to Northwestern University, where he received the Helen Kozlowski Merit Award, as well as he was the recipient of his fourth year class Sean O'Grady Scholarship for the most exceptional student going into internal medicine. As a resident, he has been an incredible leader within his class. He was one of the members of the Resident Program Evaluation Committee for his year in residency, and also one of the leaders of our Curriculum Review Committee. It really does go without saying that these are two exceptional educators, exceptional scientists, and I think more than anything else, and what I've really enjoyed more than anything this year is the fact that they are exceptional leaders. Two people who are going to make an incredible impact in their field. I am very pleased to welcome them to Medical Grand Rounds, Dr. CJ Mowry, Dr. Sarah Haeger.
All right, thank you, Jeff. So we're gonna get started. Let me find my pointer. And today we're gonna talk about a new take on wellness, cultivating a holistic approach to counter moral injury. And first, we do not have any disclosures. And then we're gonna start with a case that will be familiar to many of you. And this case starts in July of 2020, when I was starting my first rotation of my internal medicine internship in the Denver Health ICU. And walking into that unit, I thought I had a vision of what it meant to be a doctor and how I wanted to practice. And I very quickly learned how, as healthcare workers, the circumstances and system around us often constrain some of the decisions that we make and the actions that we take. And one example of this is I pictured myself getting to know my patients all personally, getting to know all about them. But when 80% of my patients were on mechanical ventilators, I got to know their loved ones a lot better than I got to know the patients themselves. And so as each day when I went down my list of patients and was calling all the loved ones to tell them how they were doing, whether it was better or worse, either way, just telling them that we hope that tomorrow was better than today. But sometimes it wasn't. And in that case, it was usually me that was calling the daughter and telling her that she couldn't come in to the hospital to say goodbye to her dad. And that was really hard. That didn't align with my vision of supporting loved ones and doing everything I could for them. And while I knew why we were doing it, I agreed with it. It didn't make that decision or that act any easier. And then when we had patients that wanted everything done for them, and we were putting another central line in them or breaking ribs as we were resuscitating them. That hurt too. And the anguish of doing things that I wasn't really sure were helping patients, and I worried I was hurting them, that seemed to stand against everything I thought it meant to be a doctor. And I didn't have words for it at the time. But when I look back now, I see that what I was experiencing was moral distress. And what I experienced for weeks or months to come as I was reflecting on that month and ruminating over what I did and why we did it, that was moral injury. And that's what we're going to talk about today a little bit more. Our main objectives today are to define moral injury and moral distress and build a conceptual model for how they relate. We're going to walk through tools to measure moral injury and how we can explore the prevalence in healthcare workers. And then lastly, we're going to talk about strategies to cultivate a holistic approach to prevent and counter moral injury. And as we go through our talk, we're going to use this outline to make sure everyone's oriented. And we're going to start with this first section, definitions and introducing the conceptual framework. Now, I think many of you in this room may have heard the term moral distress or moral injury. We know it in the last few years, it's had an increasing presence in the lay press, in esteemed journals, and in societal commentary and other features. But many of them have varied definitions of what moral injury is or how they interpret it and what to do about it. And so first we want to set a common groundwork. So when we say moral distress, the definition of that is it's the psychological unease generated from an action that contrasts with individual values. I think a couple key features here is that it is psychological or emotional unease. It's momentary, so it's situated around an event or situation. And there's an inherent contrast with internal values. So those are the two key features. As we tease apart what things lead to moral distress, we're going to introduce three more concepts. And that is acts of omission, acts of commission, and acts of betrayal. These can broadly be broken down into some of the actions that often lead to moral distress. So let's define these first. So an act of commission, that is the concern that you caused harm with actions that don't align with your values. And we'll go through examples in a second. An act of omission is not acting in ways that align with your values. And an act of betrayal is feeling let down by individuals or the institution or system around you due to misaligned values. Again, as we see, all of these involve values, and there's some conflict at play. For an act of commission, an example could be following those family wishes of aggressive treatment, even when you feel it's not in the best interest of the patient. So in that intro story, when I talked about, breaking ribs while doing CPR, potentially like futile treatment for someone or interventions for someone that isn't going to make it, but you want to honor the family wishes or the individual's wishes as well. And so there's a conflict there of worrying that you're doing harm, but also wanting to make sure you're following what others are saying. An act of omission, one example could be neglecting to use a medical interpreter while you're pre-rounding in the morning. So we've probably all cut corners before. We can imagine as an intern rounding on those 10 patients, 12 is too many for GME, 10 patients in the morning. We know that that's hard. That takes a lot of time, and we've all been there and cut corners, not used a medical interpreter. And if you reflect back on that moment and you think, well, one of my values is giving high quality, equitable care to all my patients. That would consist of an act of omission where you didn't do something, but you kind of wish you had, or you were constrained by the system for why you didn't, and that can cause distress. And then an act of betrayal. I think an example here could be the inability to care for a patient due to insurance status when you have a core value to care for all your patients equally. So an example could be, as an intern, discharging 2 patients in the same day, one of which you were able to connect to an internal primary care provider. Maybe it's one of your co-residents that you're able to call and give them sign out on this patient. They knew all the labs to order. They had everything set up for them, and they were going to follow up within a week. And then your other patient, They don't have insurance that's accepted in your network. So all you give them is a phone number, good luck, and hope that that phone number you give them can get them in quickly. And in that scenario, maybe you feel betrayed by the American healthcare system, by the health system around you, and that could be consistent with an act of betrayal. Now, many of these overlap. You can imagine many acts of betrayal lead to acts of commission or omission, where you might be constrained by the environment around you or the circumstances around you. And so you have to act in a certain way or not act in a certain way. So there's overlap here. These are kind of the main concepts we can think through. So how about moral injury? So moral injury is defined as the persistent psychological harm that results from morally distressing situations. So the key here is it's persistent. So that's really what differentiates it from moral distress, is this is lasting beyond that distressing event or situation, and it's persisting beyond that time. Again, has to relate to some kind of conflict of values at play here as well. So what is not moral injury? A common misconception is that moral injury is the same as burnout. And as we'll talk about later in this talk, moral injury can lead to burnout, but they are still distinctly separate entities. Burnout does not have to have a value conflict at play, whereas moral injury does. So not the same, but do have a relationship with each other, as we'll talk about. Exceeding duty hours. Again, this can be distressing and exhausting, which, as we'll talk about later, can factor into moral injury, but there's no conflict of values at play. So yes, it is distressing. It's not something we want, but it's not moral injury. And then lastly, moral injury is not a relic of the COVID-19 pandemic. I think COVID-19 brought moral distress and moral injury to the forefront into the literature and kind of the lay press and the medical community at large. But as we'll talk about, it extends both before and after the COVID-19 pandemic as well. So as you can see, we're going to start building this framework for how we view moral distress and moral injury. And I think another key point here is that not all moral distress leads to moral injury, and not all moral distress is the same. Different situations may cause a different amount of moral distress, which may be more likely to lead to moral injury. And if you have repeated episodes of moral distress, that may lead to moral injury, but it's not a one-to-one relationship. We can't say every event of moral distress necessarily leads to moral injury. And we'll also talk about some of the mediators at play in that development. All right, now I'm going to pass it off to Sarah.
Great, thanks, CJ. So now that we know a little bit more about what moral injury is and how moral distress can lead to moral injury, let's talk about how we can measure moral injury and determine its prevalence in healthcare workers. And so let's first talk about how we can measure moral injury. So the main methods that have been developed to measure moral injury are questionnaires or scales aimed at detecting those morally distressing events. And so again, as CJ spoke about, these are those acts of commission, acts of omission, and acts of betrayal. And so we'll look at two different scales that are widely used. And you'll see that both of these scales not only ask, did you witness or experience a moral distressing event, but how did this affect you? And so the two scales that we'll look at first is the moral injury event scale. This was originally created for military personnel, as that's where a large foundation of moral injury work has come from. But this scale has been adapted for healthcare workers, and that's the scale that we'll look at. The second scale is the moral injury symptom scale for healthcare providers, and as the name says, was specifically designed for healthcare providers. And so let's compare some questions from each of these different scales. Here on the left will be questions from the MEAS scale, and on the right from the MIS-HP. And as I said, these questionnaires ask questions about each different type of morally distressing event. And so let's first look at acts of commission. The MEAS scale asks, did you see things that were morally wrong? And are you troubled by having witnessed these immoral acts? The MIS-HP scale asks, are you troubled by having acted in ways that violated your own morals or values? Both of these scales also ask about acts of omission. The MEAS scale asking, did you violate your own morals by failing to do something that you feel like you should have done? And are you troubled by this? and the MSHP scale asking, do you feel guilt over failing to save someone from being seriously injured or dying? They both ask about acts of betrayal, both by healthcare providers that you work with and those outside of the healthcare system. One example question from the MEAS scale asked, do you feel betrayed by others outside of the healthcare system who you once trusted? And the MSHP asking, do you feel betrayed by other health professionals who you once trusted? And now this is where the scales differ. The MSHP questionnaire goes one step further and asks questions about not only did you experience morally distressing events and how did they affect you, but how did you respond to this? And so they ask questions about resilience. And so here the MSHP, one example question of this is, have you forgiven yourself for what's happened to you or to others whom you've cared for? And so another main advantage of the MSHP scale is that the authors that developed the scale also asked what score equates to significant moral injury. And so they took a group of healthcare providers, had them complete the MSHP questionnaire, and then asked them, do your feelings reflected in the MSHP questionnaire cause you significant distress or impair your ability to function? They then found a MSHP score that correlated with functional impairment. And what they found was that a score of 36 or greater was associated with significant functional impairment. And we can call this a positive score for significant moral injury. Here's their receiver operating curve from the paper they published. And this cutoff score had a sensitivity of 84% and a specificity of 93%. And so for the data that we'll show you today, a lot of these publications use either the MEAS scale or the MSHP scale and use this cutoff score as a significant moral injury. And so now that we've talked about how we can measure moral injury, let's talk about how common is it and what are the downstream consequences. And so in the last few years, there have been several papers that have been published looking at the prevalence of moral injury in healthcare workers. Here you can see 4 different papers that were published right around the time of COVID-19. Together, these papers studied over 6,000 healthcare workers. Again, we're done in that time between 2020 and 2022. And we're done not only in the United States, but also in the UK and China. And so pulling all the data from these 4 different papers, they showed that moral injury and moral distress is really common, and that 32 to 72% of healthcare workers experience significant moral injury. Nurses probably have the highest rates of moral injury, with 40 to 50% experiencing significant moral injury. However, physicians are also affected at a rate of about 35 to 40%. And if we look at a subset of physicians, looking at our residents and fellows, the GME trainees, we can see that they're probably more affected than physicians in total. And so here's unpublished data from the Better Together coaching program that was developed here at CU by Adrian Mann and Tyra Feinstad. They studied over 1,200 residents and fellows and found that 43% of GME trainees are experiencing significant moral injury. And so if you put all of this together, this means every day that you walk into the hospital, if you work with 20 other nurses and physicians, at least 7 to 10 of them are experiencing significant moral injury. And so as CJ alluded to, this is not just a relic or a product of the COVID-19 pandemic. And so this study looked at that. This was a paper that was published in PLOS One in 2022 and studied hospitalists in the Metro DC region, either before the pandemic, during September to November of 2019, or during the height of the pandemic, during July and August of 2020. They had hospitalists during these 2 different time periods complete the MEAS scale, and they found that there was no difference in the average MEAS score from before the pandemic to during the height of the pandemic, suggesting that moral injury was present before the pandemic and is still present after. And so now that we know how we can measure moral injury and that it's quite common, let's talk about the impacts of moral injury. And so I'm going to present data that shows that moral injury is associated with several downstream consequences, including burnout, job dissatisfaction and turnover, and anxiety and depression symptoms. So let's first take a look at burnout. Here are two studies, first from healthcare providers in Florida and the second healthcare providers in China. And what both of these studies showed is that moral injury is associated with burnout in each of the individual components, including emotional exhaustion, depersonalization, and disengagement. Looking more locally and at GME trainees, again, unpublished findings from the Better Together group showed that trainees with higher baseline moral injury experience increased burnout, and again, each of these different subcomponents. They also showed that trainees that have higher baseline moral injury also have increased rates of imposter syndrome and lower self-compassion. And so one study took this a step further to ask, are there different aspects of moral injury that are possible drivers for burnout? And so what this study did is they asked, are there specific Mies questions that are associated with burnout? And what they found was that there were these 4 questions that were significantly associated with burnout. And if we look for themes or commonalities between these 4 questions, we can see that the first 2 questions are about acts of commission, and the second 2 questions are about acts of betrayal, suggesting that it's those positive actions of actually committing something, feeling like you're betrayed by somebody, rather than negative acts or failing to do something that's associated with burnout. Next, let's look at job dissatisfaction and turnover. So the 2 studies I'm going to present here were both done solely in nurses, and so we'll have to extrapolate from that data to healthcare providers in general. But if we do that, these 2 studies, the first showed that there was a negative linear regression correlation between job satisfaction and moral distress. And the second paper showing that nurses with a higher MIS-HP score were more likely to consider leaving or already left a clinical position. And so finally, let's look at anxiety and depression symptoms. And while there are several papers that have shown this, here's data from one paper showing that moral injury is associated with both depression and anxiety. And so just a word of caution, all of the studies that I've presented thus far really show association, but do not prove causation. And although in our model, we're showing that moral distress can lead to moral injury, which then can lead to these downstream consequences, this relationship is likely much more complicated. And to understand this a little bit more, we wanted to determine if there are other factors that may moderate the development of moral injury. And so today we're going to talk about some both protective factors and exacerbating factors that we found. And so let's first look at, on an individual or personal level, what factors may prevent the development of moral injury from moral distress. And so to glean insight into these factors, we first asked, who is more at risk for moral injury? And so again, we looked at several studies that looked at both the prevalence of moral injury in healthcare workers, but then also within healthcare workers, who is more at risk. And what these studies found was that younger, less experienced, female, and unmarried healthcare workers all were more at risk for moral injury, in addition to healthcare workers with a mental health disorder. And I'm sure you're probably asking to yourself, most of these are covariates or co-founders for each other, but several of these studies did adjust for those co-founders and found that each of these populations individually were more at risk for moral injury. Interestingly, these papers found that practice location was not associated with increased moral injury. So whether you practice in the ICU, the emergency department, inpatient or outpatient, all healthcare workers are at risk of moral injury. And so if we look for themes amongst these different populations to try to find protective factors, we can see that many of these populations may feel like they have less community and support to help cope with moral injurious events, and they may feel like they may have less agency and autonomy to make change. And so we can suggest that maybe some personal protective factors that prevent the development of moral injury might be agency and autonomy and support and community. We additionally hypothesized that there may be some specific emotional coping strategies that may help prevent the development of moral injury. And one paper looked at this. And so looking at ICU staff during the COVID-19 pandemic, this paper found that healthcare workers with protective coping strategies like acceptance had decreased rates of moral injury, and that some harmful coping strategies were self-distraction, denial, behavioral disengagement, substance use, and self-blame. And so if we think back to the story in the beginning that CJ was talking about, working in the ICU during the height of the COVID-19 pandemic, having to tell families that they can't come in and see their loved one as they're dying, also worrying about your coworkers and trying to not expose them to COVID. If you were able to label that as a morally distressing event and moral injury and accept it for what it was, it's probably a better coping strategy than blaming yourself, denying that this was distressing at all, and trying to distract yourself. And so we can also place in here that there are positive emotional coping strategies that help protect against the development of moral injury. And so let's go ahead and add this to our framework. To next look at some structural protective factors, I'll hand it back over to CJ.
All right, thank you, Sarah. So as we go into the structural protective factors, just want to think about like what else influences this development? What other things are potentially under our control? The first thing we're going to look at is the concept of value concordance. So this essentially means how concordant are the values of an individual with the organization or system that they're working within. A number of studies looked at this. This first one asked a similar question along the lines of what was the ethical climate and how did that impact moral distress? And in this study, what they did is they sampled healthcare workers and asked them how favorable was the ethical climate they were working in, and then also asked questions getting at what was their level of moral distress. On this, we have on the y-axis the ethical climate, where a higher score means it was a more favorable environment. On the x-axis, we have moral distress, where a higher number means more moral distress. And they found a negative correlation, which means that on average, from population level, they saw that healthcare workers that had a more favorable ethical climate, that they had lower levels of moral distress. Another study asked very similar question, value concordance, how does this impact betrayal-related moral distress? And they found that there was indeed this pretty significant correlation where when individual healthcare workers perceived that the organization or group that they worked within had concordant values, that was protective, with about a 3 times lower risk or lower odds of having moral distress. One of the sample analyses they did was, how did feeling betrayed by institutional leaders impact moral distress? And similarly found approximately a 3 times increased odds of having moral distress among that population. An article in Journal of Internal Medicine took this one step further and asked, well, how does value concordance associate with well-being and some of those other downstream effects? And they found that when clinicians' values and the values of their organization were discrepant, were pretty different, there was reduced care compassion, reduced job satisfaction, as well as increased levels of burnout, increased absenteeism, and increased desire to retire or cut back on clinical time. Another study tried to tease out, well, what's driving this? Why is there value discordance? I think we can think of a lot of reasons why. One of the major themes that they found is reflected in this quote, which states that the increased revenue is what we were asked to be doing. Rather than what is best for our patients, we have a healthcare system in this country that is about making money and not about keeping people healthy as its core objective. And providers are suffering moral distress because of it. And this was a recurring theme in the sample of hospitalists and residents that they sampled at this specific teaching hospital. And one of their major conclusions was that the perceived corporatization of healthcare has created administrative and financial pressures that conflicted with the core values of both residents and hospitalists. And this makes sense. If you're constrained within a system for how you act, you're more likely to feel betrayed, more likely to act in ways that you don't really want to or don't align with your core values, and that can increase moral distress and moral injury. So we're going to leave value concordance when values are similar between individuals and organizations as a protective structural factor. Next, we're going to talk about empowerment and autonomy and hierarchy. Researchers started to ask, is there a relationship here based on some data that Sarah shared showing that nurses seem to have more moral distress than residents who seem to have more moral distress than attendings. And we know that in general, autonomy across these groups declines as you go along. So nurses typically have less autonomy than residents who typically have less autonomy than attendings. If a resident or a nurse is told to do something by the attending, they usually feel like they have to do it. And so the same study that was performing semi-structured interviews with hospitalists and residents posed this as one of the questions as well. And another sample quote is listed here, where the culture of medicine is such that the way we learn is to propose something to our superiors and get feedback on it. This does not leave a ton of room for having trainees feel empowered to express when they feel like their team is doing something wrong. So in this study, they showed that even when a resident felt like their team was doing something that conflicted with their values, they felt like it was challenging to push against that and to challenge that. And we have hierarchy in medicine for a reason. We're trainees. We want to have that supervision and everything, but we also want to have an environment that is supportive of everyone's individual values and can express those values in a safe, psychologically safe manner. Another quote from a similar study among ICU healthcare workers is, oh, sorry, let me jump ahead. So another quote from a study looking at ICU healthcare workers left this also rather provocative quote stating that there are definitely patients that disturb the nursing staff because they are the ones who have to carry out the doctor's orders. The suffering goes up the chain, but I feel that each step is slightly further removed from the patient, so they're seeing less. And so the resident who made this quote was seeing that nurses felt like they had to follow the orders of the physician, regardless of if they were in line with their own values or not. And interns felt the suffering a little bit more than the residents, who felt the suffering a little bit more than the attendings because they were just closer to that environment. So again, I think supports how without empowerment, without that psychologically safe environment, that can also lead to increased levels of moral distress and moral injury. So that's why we're going to list empowerment up here as a structural protective factor. The last one we're going to talk through is community. And this was first looked at in the military population in veterans returning from deployments. And they asked, like, what's the association between social isolation and moral injury? And they found that there is a negative cycle at play among these groups, where when they experienced moral injury, they then felt like they didn't belong in the group that they were part of when they were deployed. So they felt this lack of belonging. And then because of that, they didn't reach out for support. They felt socially isolated, and they were more at risk for further moral injury. It was this kind of negative cycle that they were seeing among military veterans. And so healthcare researchers asked, well, is this also at play in healthcare? And in fact, it is. So when healthcare workers perceive that they have low social support around them, either from colleagues or from supervisors, they have a significantly greater risk of having moral injury. Which this can make sense as well, is if we don't feel like we have a support system around us, we're less likely to seek help or recognize that others are experiencing this as well. And that can influence those personal protective factors that we already mentioned. So we're going to add those structural protective factors to our framework. But things are getting a little bit busy, so we're going to try to simplify this a bit. And if we think about our personal and structural protective factors that we mentioned, and we try to combine them together into a common thread, we would argue that this is resilience. So this is moral resilience or value resilience to help prevent that progression of moral injury from moral distress. I think commonly we hear resilience in the literature, and I think it's often perceived as just a personal thing, but we would argue there's a lot of factors that play into resilience. It's hard to feel like you can reach out for help if you don't think that you have any of that help around you. And so we're going to put resilience into our framework. But even here, this doesn't feel like it's capturing the entire picture. There seems to be something else at play that's factoring in and blocking those personal or structural protective factors. And researchers looked into this as well, and they concluded that mental and physical exhaustion seems to inhibit the ability to cope properly, to reach out for support, prevents acting on some of those personal and structural protective factors. So what's the data here? So this study looked at healthcare workers and how stress and resilience and well-being were intertwined. And they found that there was a number of factors associated with moral distress, including heavy workload, long hours, increased job demands. We know that individually, as we talked about, long work hours is not by itself moral distress or moral injury. There's no values at play there. But when healthcare workers have that heavy workload, are working long hours, or increased job demands, they seem to be at increased risk of developing moral injury from those morally distressing events that we all experience. Another group of researchers try to figure out, well, what is this driver? Why is this happening? And one quote from the study showed that when doctors feel overwhelmed by their workload, they're less likely to seek support from colleagues. So similar to what we've been saying. And again, they found that when healthcare workers had heavy workloads, were working long hours, or were in stressful situations and had stressful interactions, they were more likely to use those maladaptive coping strategies that we talked about earlier. So they were less likely to utilize acceptance or some of those positive protective coping strategies because of that mental and physical exhaustion. So we're going to add mental and physical exhaustion to our framework. And then you may ask, well, what about all these other downstream effects? And we would say, yes, those also feed back. This is not a simple model that we have necessarily, but we know that when healthcare workers are burnt out, there's that emotional exhaustion at play, and that factors in to some of those personal protective factors. Same with job dissatisfaction and turnover. So if everyone around you is leaving the job, that's your support and that's your community leaving. So that also factors in to the structural resilience that's at play within an organization. All right, now I'm going to pass it back to Sarah for start of section 3.
All right. So what we've shown thus far is that moral injury is common and is associated with these adverse downstream consequences. But what can we do about it? How can we intervene to stop this? And so we're going to show you a holistic and 3-tiered approach that we propose that may help prevent the development of moral injury and counter moral injury. And so looking at our diagram, the first tier of our approach really centers around a better understanding of moral injury and awareness that it exists. The second and third tiers of our approach really focus on enhancing that resilience or protective factors and reducing mental and physical exhaustion, either at an individual level or a structural level. And so let's take a look at our proposed approach. So first, we propose that you establish a conceptual foundation of moral injury and to measure it regularly. Once those you work with around you know what moral injury is and it's being measured, you can then develop avenues to discuss moral injury and cultivate self-compassion, again, enhancing those personal protective factors. And then finally, on a structural level, we propose that you invest in organizational changes to improve structural resiliency. And so let's look at each one of these individually and how we can do this. So let's look at the first tier. To reduce the rates of moral injury and impact of moral injury, healthcare workers first need to know what it is, have a language to talk about it, and know how affected they might be by moral injury. And so how can we do this? So if we extrapolate from a completely different arena, but think about 5 to 10 years ago, not many of us knew very much about what a microaggression was, what implicit bias is, or what it means to be an upstander. But really with education, training sessions, and a common language within the last 5 to 10 years, this has really increased knowledge about fundamental principles of aggression and harassment, has created a common language for easy discussion about these events and these issues, and then further has encouraged organizations to measure and track these events. And so can we do the same for moral injury? And we argue yes. So we propose considering creating educational curriculum to introduce the concepts and a common language for moral injury. Within the curriculum, this should include defining moral injury and talking about its causes and downstream consequences, and then also having attendees determine their individual values so that they can recognize circumstances when those values may come into conflict and cause moral distress and moral injury. We second propose that you measure moral injury regularly in yourself, your staff, or trainees by maybe completing that MEAS score, that MIS-HP scale every 6 months. We should also identify common events that are morally distressing, as this will allow implementation of further interventions and the ability to measure their efficacy. And so once we've established a conceptual foundation and common language for moral injury, we propose that you develop avenues to discuss moral injury and cultivate self-compassion. And so again, these are trying to enhance those personal protective factors, mainly support, community, and positive emotional coping strategies. And so 3 main ways that we can do this are through coaching programs, small group discussions, and peer support programs. And so today I'll show data or evidence for coaching programs from our Better Together coaching program here, for small group discussions from the Schwartz Center rounds, ICU moral case deliberations, and Ballant groups, which are all small group discussions that are focused on the ethical, emotional, and social issues that physicians face and healthcare professionals face. And then finally, the third, I'll talk about peer support programs, or something called Battle Buddies, which was a peer support program that was developed at University of Minnesota during COVID-19. And so let's first look at the Better Together coaching program. And so this was a coaching program that was instituted here at CU and originally studied women physician trainees. They had physician trainees either undergo an intervention, which was the coaching program, and compared these trainees to those of a control group. Now, this control group was also trainees that were interested in the coaching program, but were assigned to placebo first and would get the coaching program later. And so they calculated or measured the MIS-HP score in their trainees from before the coaching program to after. And in those that got the intervention or coaching program in comparison to control, there is a greater absolute decrease in the MIS-HP score, or a reduction in moral injury in those that got coaching in comparison to those that didn't. And so if we try to determine why the coaching program might work, the authors also found that trainees that experienced the coaching program had a significantly increased self-compassion at the end of the study period. And looking at a qualitative study that they published, they showed that 2 main themes from the coaching program that trainees really liked was that it increased a sense of community, and they also felt like it was helpful to practice metacognition as a tool for healthy coping. And so let's also look at some different small group discussions. And so here's a paper that looked at Schwartz Center rounds, which again are just small group discussions focused on talking about social, emotional, and ethical issues that healthcare providers face. And this study found that 50% of physicians that attended one Schwartz Center rounds had a reduction in moral distress after they attended these small group discussions. Looking within the ICU, a group studied ICUs that set up something called a moral case deliberation, which again was small groups kind of looking at cases that had difficult ethical or moral issues. And they compared this against ICUs that did not have these moral case deliberations. And they found that healthcare providers that worked in the ICUs that had these moral case deliberations had decreased moral distress after implementation of these. And then finally, looking at Ballant groups, which I know are present here on the CU Anschutz campus. While I couldn't find any quantitative data, there is qualitative data suggesting that this works, and that these 2 publications discussed that moral distress and injury was a theme that was frequently discussed. And here's a quote from an attendee that went to these Ballant groups, saying that it was really nice knowing that other people were having and facing these same issues that they were, and it really created a sense of community and support for each other. And so finally, let's also look at peer support programs. And so this is the Battle Buddies program that, again, was a peer support program where they put two peers together to talk about these social, emotional, and ethical issues. This, again, was done at University of Minnesota during the COVID-19 pandemic. And again, while there's no quantitative data, the authors suggest that they had anecdotal evidence showing efficacy. And so we propose that you consider all three of these. We propose that you consider developing a buddy system for employees and trainees within your program, department, or division that also provide opportunities in small groups to discuss these emotional experiences and morally injurious events. And that finally, while it takes a lot of infrastructure and investment, it's really important. And so consider providing opportunities for coaching to help cultivate self-compassion and moral resilience. And so for the final tier of our approach, I'll hand it back over to CJ.
All right, so in the third tier, we're going to talk about how can we invest in organizational changes to improve structural resiliency. And I want to also make the point that when I say organizational, I really mean much broader than that. So from the individual medical teams rounded in the hospital, how can our resident and faculty leaders make change? From our department level, how can we make change within departments? And then from the hospital system, how can we make these changes? I think each of these will apply in a slightly different way to each of those groups. And so we're going to refer back to each of those main structural protective factors, as well as the impact of exhaustion. Then we're going to talk about some avenues and areas for future research. So value concordance, we know that if we can close that gap between healthcare workers and the values that are perceived to be present within that whole organization, we seem to be able to reduce moral distress. I think it's a very challenging thing to do, but we know it can be done. We know it's being done. I think a local and timely example is Denver Health. Now, I was the chief at Denver Health for the first 6 months of this year, and I got lots and lots of invitations to town halls and small group meetings and all these other meetings where they are inviting everyone in the workforce to come and weigh in on what their strategic plan was going to be for 2024 to 2026. Now, while this is still being rolled out and developed, they developed these values listed on the far right of respect, belonging, transparency, and accountability with that involvement of stakeholders. So this is how it could be done at a large system level. But we know that just defining values and putting them on a website is not enough, because it's actually the perceived values that are what's really important. So what do the healthcare workers think are the values that they're working within? And so I think it's also important to measure those values. Like, do we know what those within our group think our values are? And how can we then change to close that gap? This Building Trust campaign, an initiative with the ABIM Foundation, has a lot of fantastic resources for how do we build trust and build that value concordance in healthcare, all the way from small department or small group level all the way up to the entire systems. And some of what Denver Health is doing was actually pulled from this initiative. So I encourage you guys to take a look and look through their website. I think about empowerment. This is one that really spans that whole spectrum of, as resident or faculty leaders on a medical team, are we involving our team, all their team members, our nurses, our medical students, our residents and trainees, to make sure that we have that psychologically safe environment where they can share their thoughts. If they're feeling like what the team's doing is discordant with their own values, we want to know. And we want to make sure that we promote that team-based decision-making. So even if we are doing it for another reason, at least everyone understands why we're acting in a certain way or doing a certain thing. And from the organizational level, I think, like Denver Health is doing, try to involve as many people as we can. It takes a lot of time and effort, but we think that that can achieve that value concordance. And as trainees, you know, I know that I didn't go to anywhere near as many of those as I probably should have. Like, we need to take a seat at the table and we need to share our values, because otherwise, how are they going to represent them? So I think taking up those opportunities when we can to influence and guide some of those organizational and larger group plans going forward. Then community. I think we all know that community took a hit with COVID-19 and we lost a lot. We lost a lot of, you know, retreats. We lost a lot of social gatherings, and we've started building it back, but we still got a lot of Zoom. We're missing out on a lot of in-person interaction. And it's really challenging to build that community without those things. And so trying to figure out ways within your small groups all the way up to organization system level, how can we invest in initiatives to foster community support, belonging? I would like to credit some of my co-chiefs who helped develop rainbow events within our residency, which is essentially events where we invite everyone in the residency to come and they relate to some kind of social, cultural, or other event. And we just try to build that community. It's hard in trainees because our teams are all constantly changing. We are hardly ever with the same team again. So how do we build that community when we have that changing environment around us? Then as an organization, thinking about how can we identify and then resolve those causes of mental and physical exhaustion? And again, looking at our residency, they saw that the structure of resident training was causing emotional exhaustion, burnout, and these other complicating downstream effects. And they changed it. We switched to the 4+4 model and saw almost an immediate decrease in emotional exhaustion, just shown on this table up here. So thinking about how do we identify those opportunities to remove causes of exhaustion? And lastly, I want to make a plug to invest in research. We mentioned some of these early articles that have been more prevalent in the press, but a lot of them are perspectives. And we know from reading through lots of research that there's lots of gaps with moral distress and moral injury. We don't know what interventions work. We don't know which ones prevent downstream effects. And so there's a lot of opportunity here to learn more and figure out what can we do to change this. So thinking about on small level all the way up to the large level, how can we support these initiatives and try as a group and a community to reduce moral distress and moral injury? And so from the overall organizational level, we propose trying to model change after value concordance, empowerment, and community in mind. Trying to find ways to commit to reducing emotional and physical exhaustion, and supporting and investing in research and other initiatives to try to cut back on moral distress and moral injury. And as we leave you with this framework we built today, we want you to take a moment and think about, where can I act on this pathway? How can I prevent moral distress around me? How can I prevent the development of moral injury? How can I alleviate mental or physical exhaustion? And as I reflect back on that initial story I shared, I think about how things could have been different. I think about how if I had known about moral distress and moral injury, I could have put a label to what I was feeling. And we know that labels have power. And if I had that label, I could more easily address it or share what I was feeling, recognize that others were feeling it around me too. And then we could talk about it. We could have those small groups. Maybe there's a small group meeting every Friday that I could go to and share my experiences and build some of those adaptive coping strategies to move on. And I think also thinking about how can we develop that moral sensitivity to recognize when we're putting someone else in a position where they may have to act against their values. How do we address that? How do we recognize when someone around us is experiencing moral distress? And lastly, as I'm walking out of the ICU at the end of the month, maybe I see that there's an initiative within the hospital that is trying to reduce moral distress and moral injury. And maybe I can get involved and share my own experiences and take those to the table and find ways to address them there. And so with that, we're going to leave room for questions, but thank you so much for having us today.
DJ, Sarah, thank you so very much. We'll start with questions from our live audience. Dr. Allen.
Really nicely done. Thank you. One question I have is, you talked about a lot of these pressures come from the corporatization of the American medical system, which, some of that's going to happen no matter what. But in your solutions, you didn't really touch on it. And one of the questions that I have for you is, how much of this is being externally imposed upon us, and how much are we either helping it along or being complicit to it? And the reason I say that is I get a lot of complaints that come to me, and those complaints are often, I'm burned out, we're working too hard, we're being asked to increase volumes, but potentially a more common complaint I get is I'm not paid enough. And I do think one of the solutions to this is that if we want to accomplish a lot of things that you said, we actually need to think about what is a reasonable compensation for having that kind of approach. So I'm just curious your reflections on that.
Yeah, I think that's a great question. And I think a whole nother talk in itself and a whole nother area of research that we probably need to learn more. Because it's true. I think, corporatization and the business of medicine is going to happen regardless. And so I think trying to identify, how do we work with that system? How can we find ways to, potentially use it to our advantage if we can as trainees, and especially in like the training system, I think is one of the areas that I've been thinking about probably most closely, because that's the area that I'm in, is that trainee realm. But I think it's hard, and I don't know if I have an answer for how do we address it. I think that's one of the areas where we need to try to at least start thinking about it, and what are the impacts of that, and how does it influence our workforce and the healthcare workers as a large. So I don't know if I have an answer for you, but I think it's definitely something to be thinking about.
Dr. Ernest?
I would also congratulate you on a great talk. So one of the, and this is sort of my opinion, but I think one of the great sources of most of the moral injury we see has to do with distribution questions. So, and most of us take a justice orientation to that. So we can give something to somebody that we can't give to somebody else, and that's fundamentally why we experience that. And that the reason we're forced into that is that we have globally a system that really does distribute it as a consumer good. And we don't distribute consumer goods based on a justice orientation. We do it based on who can pay for it. And so I appreciate the way you sort of started at the local and went to the global, but there's one level beyond that, which is in fact the policy environment we're in, our social and civic structures. And so I guess I would be interested in your thoughts. And I think there's often a tendency to not feel like we have agency at that level. And yet I think that really undercuts the power we have as a profession, both individually in our lives as citizens, but also collectively through our professional societies and things like that, to actually change a system that would have a different orientation on distribution and justice. So interested in your thoughts on that.
Yeah, I think that, sorry, I took this, I read about, this is one of the areas that we thought about a lot, but didn't have space in our slides, because I think it's true. Like, we have to, again, take a seat at the table when we have that opportunity, and where can we make changes to eliminate some of these causes of moral distress and moral injury. And there is data showing that healthcare workers who are empowered to advocate and act in either community associated organizations or policy and advocacy associated groups, they actually have lower levels of moral injury. So when healthcare workers are empowered to act on the distress they're seeing around them, that is actually protective, and probably like a protective coping strategy, and just better for our system as a whole. So I think that's also another part of our framework that maybe we didn't say explicitly, but is definitely at play in everything. I don't have anything to add on it.
Yeah, no, exactly what you said. Really just trying to get involved in advocacy and advocate for policy changes when you're able to, and trying to make those opportunities for yourself rather than just kind of like waiting for them to come into your lap.
Give our last thought to Dr. Winia.
Yeah, I'll echo what others have said. That was a wonderful sort of comprehensive overview of this field. I want to make one pitch and then leave you with one research question. The pitch is that the ethics consultation service here at UC Health provides moral distress or moral resiliency rounds. And so you can, through the ethics consultation mechanism, if there's a specific case that is creating a great deal of moral distress with the team, we have people who are specifically now trained in moral distress, naming it and adaptive responses to those kinds of very difficult situations. So that's the pitch. The question is, you mentioned in the factors that might be protective or exacerbate moral injury, the idea of self-blame. But there's another aspect of blame, which is finding someone else to blame for the cause of this problem, right? Whatever the problem is, if I could just find someone else to blame, I'll feel better about it. And yet, blaming others is kind of analogous to one of the core features of moral distress, which is feeling betrayed. And I don't know that anyone has really dug those apart. But the idea that it may be either improving the situation or making it worse to try to find someone else to blame when you are experiencing an event that's creating moral distress in the team.
Yeah, that's a great point. I think, the papers that I presented, it really showed kind of self-blame, but then didn't look at blaming others. But if we think about how acceptance may be the opposite of blaming yourself for others, and by recognizing what's happening, accepting that it's there, that may suggest that, yeah, more acceptance rather than blame may be a protective coping strategy.
We are right at time, so I'm going to ask others with questions to come up front, but Dr. Haeger, Dr. Mowry, thank you very much.